Welcome to the Living Medicine podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show.
Hi, everybody. My name is Dr. Sandy Newis, and I am with the Living Medicine Institute, a training and content program for professionals interested in psychedelic-assisted psychotherapy, specifically ketamine-assisted psychotherapy. And we are sponsoring this podcast, and I am delighted to be with Dr. Manish Agrawal. And I am delighted that you have chosen to honor me with your presence and for being on this. And I'm just really happy to have you here. So for those of you who don't know, Manish is the co-founder and CEO of Sunstone Therapies, which, if you're not aware, they are very much the leader in the delivery of psychedelic-assisted psychotherapy in the medical setting. So they have really pioneered and kind of held and continued to carry the torch forward with psychedelic-assisted psychotherapy research. Dr. Agrawal brings an extensive academic, clinical, and research background and depth of experience to Sunstone. And what I just found out from Laura, his colleague, is that this spans medicine, engineering, philosophy, and ethics, that he has many degrees and has been involved in many different efforts, that we're all very lucky that he has taken that expertise and really applied this in this particular field. One of the things that he says is that he's driven by a really deep interest in healing, and that he's passionate about whole person healing and the transformative potential of psychedelic therapies. He previously held the position of co-director of clinical research at Maryland Oncology Hematology, where he dedicated 18 years to the care of cancer patients, and then has turned to psychedelic-assisted psychotherapy. So, as I said, I'm really honored, and I'm happy to have you here. So thank you so much for this.
Thanks for inviting me. I'm looking forward to speaking with you.
Yeah, good. Well, thank you. So, my hope is that we just have this really be a conversation. I'm excited to have the chance to kind of pick your brain and understand a little bit more about Sunstone and how this all came to be, and some of the aspects of the research, and maybe we can talk a little bit about training, as I obviously have a vested interest in that. But yeah, so first of all, if you could tell us, what is Sunstone, for those who don't know, like many do, but a lot of our audience are not psychedelic people. They are people that are interested in this field and here to learn. So, lots of us who are involved in the psychedelic field really are, cheering you all on. But imagine somebody doesn't know anything about what Sunstone is specifically within the psychedelic field. And, if you could just tell us what you all do.
Sure. Yeah. So we're, as you said earlier, we're setting the standards and setting what does it look like to deliver psychedelic therapy in the medical setting. So it's really a new specialty that's being born out in medicine. So it's different than traditional psychiatry. I tell people, because most psychiatrists, either it's prescription medications or therapy. And this is much more extensive. It's 8 hours of treatment, there's prep, there's integration, there's a multidisciplinary team, there's a physician, a therapist, an MA, there's labs. So it's medical and psychiatry. And so it's really a different type of care, and it's a new paradigm. And so we're really looking at all the aspects of that and what it takes operationally to run a center, what are the people that you need. Because this, like I joke with people, I said, probably doesn't matter that whether your surgeon you get along with or not. As long as your gallbladder comes out, you're good.
Right.
But really, to get the most out of psychedelic therapy, you have to feel very safe, and you have to be able to trust where you're at. And that starts with every part of the organization, from the time that you set the website, the phone call, to the therapist. It's not just the therapy. And so it's really it's a lot of different moving pieces. Like for one person, it could be 20 visits with 4 or 5 different providers. So how do you really juggle all that where it feels seamless? And so long-winded way says, how do we do this well with the patient at the center?
Right. So, mind if I just kind of like take a
Jump
little
in.
side
Yeah.
journey on that one? So, you, as founder and administrator and holder of the model and the vision, how do we teach that? Like, how do I mean, because in the first like 2 minutes, you just hit what I think is such an important aspect. Like, the providers at every step of the way are holding these clients in this bubble of care and of trust, and we communicate with them on many levels. And so, when you have as large of a system that you have, how do you work with that? How do you help create that safety?
Um, I mean, it takes a lot of different aspects, but I would say that it starts, and people will be surprised that maybe I start with culture. And so
Mm,
our our two deepest values are love and rigor. That's what we say. And so people should be able to come and experience that, but also feel the rigor of our process. And the patient is at the center of it. So if we keep coming back to that, and everything that we do, that we ask, that we create, doesn't always meet those standards, but that's what we're striving for. And so if you keep that as the backbone of what you're trying to do, then you end up shaping systems to form and support that. And then you hire people that believe in that vision. You create systems that do that. Because you can't micromanage each thing. So that has to undergird it. And if that's not held all the way throughout and that's not valued, you can't do it. You can't piece of, but people think, one of a good friend of mine now, and uh, George Kimball, he started the Stanford Design School,
mm,
and is one of the first. It was the first design school really in the country. Now there's lots of them, and so people say this place is amazing. They'd come in and say, "Look, what are you doing?" And they'd see like his desk, and he had like a thing of green M&Ms and a lamp, and then so they would go copy that as if that was it. And so
All right, we got to get the green M&Ms. Here's the lamp. Okay, are we good? Let's do
so
it.
you can say like, "Oh, we use this website or we use that software."
Yeah.
It's the other thing underneath it.
Well, that's interesting because that's really analogous to a discussion Signy and I were having earlier about, what makes good ketamine assisted psychotherapy. And, people think it's the medicine, like it's the green M&Ms,
Yeah,
and that's like, that's just a tool,
it's
right?
just a tool.
So, yeah. Well, and kind of along these lines with this work. So, how did you switch from engineering into oncology? And, but like really the switch from, it's my understanding that you started this oncology center and the research associated with it, and then pivoted from that into taking that and then developing the psychedelic assisted psychotherapy piece. Is that accurate? And if so, kind of, what drew you to that?
Um, so to make a short story long, um, I could start anywhere, but if I start in college, when started college, I wanted to study philosophy. And, my dad said, I didn't come to this country for you to be a philosopher. And
Oh,
so,
interesting.
so
Uh-huh.
I said, what do you want me to do? And he said, do engineering. That way, I know you can get a job and you can do whatever you want.
Mm,
But, even at that early age, I didn't recognize, but I was interested in questions of meaning and, in essence, like what makes us human, what makes us tick. Um, and so I did engineering and I like problem solving, but then I didn't really love engineering. And so,
mm,
my junior, senior year, I said, I don't think I want to be an engineer. And so then I thought, well, maybe I'll do biomedical engineering. And
mm,
so that led me into medicine, saying, well, I'll do biomedical engineering. And so I went to med school, and then I said, wow, I really like talking to patients. And so
mm,
that led into medicine. And then I thought I was going to do cardiology, but then when I was doing my rotations, I loved talking to patients and having meaningful conversations with them
mhm.
rather than sort of superficial ones. And oncology did that more than any other specialty, except for potentially psychiatry, but that's old time psychiatry. The new time psychiatry wasn't that. Certainly
Right.
inpatient psychiatry wasn't meaningful
Right.
conversations. And so that led me into oncology. And I loved oncology. I really had great relationships with my patients. We talked about everyday life, but I got to know them in a way that was profoundly touching to me,
Mhm.
and to them. And then probably 17, 18 years in it, I started getting burned out
Mm,
because I saw that even though so many people were living longer and we were able to treat their disease, um, so much of their quality of life was determined by their inner state, by their mental health, and really didn't do much about it. And
mm,
so to close the door on patients and walk out of the room and knowing that their life is sort of shattered and their families, and you don't give them a lot of tools, and they're not a lot of great tools.
mm. Right.
And that's when I heard about psychedelics. I'd never even heard about psychedelics. I didn't even know what psilocybin was.
Interesting.
Um,
Uh-huh.
you know, people experiment in college. I didn't even drink in college.
Oh.
So I'd never heard about psychedelics till, I don't know, 6, 7 years ago.
Can we just kind of take a moment of appreciation of that? Because a lot of people think like, oh, everybody in psychedelics was like a psychonaut and they've been doing it the whole time. Like, that's just not factually true. You know,
No, I
like
mean,
there's a lot of space in this for professionals who this is brand new to. So I love that. Thank you for bringing that up.
absolutely. And I would even say, not just come back to why I get into psychedelics, but along that, though, I will say a plug in for there's a lot of controversy in the field about like, do you need to have done psychedelics before you can be a therapist?
Mm.
And I'm not here to necessarily have that discussion, but I will say in training of therapists that we've done and people that we've seen, I'd much rather have a really good therapist who's never done psychedelics than someone who's done a lot of psychedelics and thinks they've seen God and now is ready to be a psychedelic therapist.
Oh, for sure. I
Um,
completely agree with that.
and so I think I tell people to have good real life skills and then bring that into psychedelic therapy or into psychedelic work. You
Hmm.
need that more than sort of a psychedelic expert. Anyway,
Yeah.
they asked me that question, but um, so then I heard about psychedelics and I uh, read about it and I said, wow, they are talking about dealing with existential crises. And we don't even talk about that in oncology. Like, I go to the oncology meetings and all the abstracts are about chemo. Nobody talks about loss of meaning.
Well,
And
by
so
the way, right, your quality of life is going to dramatically decline. Everything's going to change, and
like
you
we
may
just
not survive this.
it's the elephant in the room that's never talked about. Like these people are
Right.
like talking directly about it. So
Yeah.
um I went and became friends with Roland Griffiths and uh that's another story I'll come back to. But
I bet that's a good one.
and so I ended up writing a study that got IRB and FDA approved
Mm.
and told my group I want to do this and raised money and built out a space and started doing so we did the first group study uh using psilocybin in cancer patients in the outpatient setting. Uh
Oh, so you bridged those gaps,
yeah, I bridged those.
bridged the cancer and your interest in kind of the existential and the human and the suffering and the alleviating suffering component with the psychedelics.
Yeah, so when I was wandering all those times, I thought I was just going from one thing to the next, but now I can look back, those were that was the crumbs I was following.
Mm-hmm.
The way this
Interesting.
work sort of brings together all of those interests.
Yeah, I love that. So let me just also highlight, you're like, oh yeah, we just like wrote a study, got our review approval, you raised money, built out a space, like as if those are like simple things. Like I love that you just kind of toss that out. Like, yeah, how long did that take you from like the beginning of the writing of the proposal to the actual kind of launching of the first study in the new space? I'm just curious.
Yeah, it was a really interesting time. You know, study probably took about a year to write.
Hmm.
Um, and then, I mean, the whole story is kind of funny. I mean, it's like hard to believe, but like there's an open shell and I said, I want to do this work. And I talked to this man who's an incredible guy, whose wife had died of ovarian cancer. And I didn't say it in these words, but in essence, I said, this is to help treat broken hearts. And he said, well, that's what I wanted to do. And so he said, fine. Scylla what? I said, psilocybin. And so he never heard of it. And he wrote a check for us to get architectural drawings. So I got
Wow.
drawings and there's like, they said it was going to cost, I don't know, 1.2 million or something to build it.
Uh-huh.
December, we did this fundraiser, December of 19.
Oh,
Then COVID hit
yeah.
and we raised some money, but we started construction. And the people were
Uh-huh.
like, nobody starts construction without all the money, but we just did. And then the money
Uh-huh.
just trickled in. And I don't know, we did the fundraiser in December and we had it built by July, August. I mean, I should say the person that's not on this podcast is Kim Roddy,
Yeah.
and she really built the space out. She's like the operational genius behind all of this, and she's oversaw the project, built it out, did all the stuff. I do the hand waving, she does the work.
Well, having had the honor to spend some time with Kim, I can certainly appreciate her contribution and yeah, appreciate you recognizing that. So you two are a good team.
Yeah,
I mean, that's pretty fast.
it's
Like,
pretty fast.
you
We were on
know,
a It is strange. COVID actually worked for us in that time. It's like because so much construction shut down, but it was
mm,
continued medical settings, and so people are able to work here and do it. And
nice. Yeah.
I mean, it was a strange time. Like the county was going to close and not give permits out, and so a developer we knew got the permits on a weekend before the
Uh-huh.
county closed, and
Well,
so like, all these things sort of
interesting.
is
Right.
like it was a it was meant to, it was like some we were possessed, thing was possessed. It just sort of happened.
Right. If one believed in following the signs, one might have thought that that seemed like a very clear sign that you were on the right path.
Yeah, we never believed that. We just stepped in through one door, and if a door opened, we just kept going, but we didn't
Yeah.
know how to play out.
Yeah. Well, has research always been a piece of it for you? Like, has it been kind of, it sounds like you wrote the proposal and then the clinic came. Most people think about doing it the other way. So I'm just kind of, you've got a clinic and then you try to do some research. So, um,
Well, I mean, so I've been doing research for my whole time. So I mean,
yeah.
went to the NIH and I have a master's in research from Duke and was on faculty there. And so I sort of got bored, honestly, with oncology research.
Mhm.
And then I didn't finish it. So I actually, during my residence at Georgetown, I took a year off and got a master's in philosophy and did
Oh,
ethics. So I was doing research in ethics as well at the NIH, and I got a little bored with that. It was like, um, but so research, yes, in the terms of asking questions,
yeah.
but at the time and currently still, because psychedelics are Schedule One, the only way you can study them is through research. And
Uh-huh.
so, but this allowed me to ask questions that I really cared about, like how do people face death? What
Mm.
happens when you lose meaning? And so
Oh,
there is a part of me that is genuinely interested. And so a research question was important practically to be able to do anything and to study it and to do this work. You can't just go out and give psilocybin. But I also was interested in the evidence and like, what does this really work? So that's always been a part of who I am.
yeah. Well, so I'm sorry if I derailed the kind of, how did you get there piece. I realized that I did. And, I'm hearing as you're talking about it, this weaving together of like, engineering and then ethics, philosophy and then medical. Like, so I can see how all of those things weave together for you. And I mean, did that ultimately lead you to cancer kind of because bringing those things together?
Yeah, cancer, because I think at the heart, I really enjoy meaningful conversations with people. And so cancer sort of cuts to the chase like nothing does. And
Yeah.
so people get very real and you're talking about what matters. And so I really enjoyed that. And then I enjoyed the technical aspects of it at the time of how do you really manage a complex disease with multi specialties and whether it's chemo, radiation, and surgery and different nuances. And how do you guide someone through that piece as well as the psychological aspect of it? And so cancer really called a lot from me to do that.
Well, so kind of, and then so bridging that with psychedelics, does it feel like a natural progression of that? Or is there other things about that that really just excite you about being in the field or interest you about being in that field?
Um, yeah, for sure there's a natural bridge because basically I have even deeper conversations and have dropped the chemo and the radiation and the surgery. And so now we just talk about really deep things. Um,
Mhm.
and so, yes, I think you can have incredibly meaningful conversations with people about, you know, things that they don't even understand or you don't even understand about themselves. So that part of it for sure, it's been a natural extension. And then, I guess all these things sort of make sense as I look back. I've always been a pretty pragmatic person. And so I liked philosophy and those things in like real life. Like, what does it really matter to you as a person? And when I got my master's, I realized I didn't want to get a PhD because got really academic and ethereal and like you're sort of solving questions in your head, but they're not like practical ones. And so in a way, this is like the best lab for those kind of questions because you get to see humanity sort of naked,
Right.
unbridled.
Yeah. Yeah. I love that. Right. Which we certainly do see in psychedelic land.
We do.
I mean,
Well, we
we were
see it everywhere, but we see it really in your face in psychedelic land.
right. Yeah. Yeah. Well, so what are so you run a clinic that does clinical work and also does research. So, what are some of the interesting things about that for you?
Um, well, I think it's interesting is I'm continually learning. Like you never sort of come to the bottom of this. Um, and so I think my first foray into it was, wow, this is really powerful. These people know all this stuff. And then now that I've done it and treated a lot of people, I'm like, well, they knew some stuff, but they were wrong about a lot of things. And there's a lot more to learn than and a lot more to unlearn. And so that's been sort of interesting to me. And the other thing that I'm really interested in philosophy and just in general is like sort of philosophy of mind, sort of like this intersection between you call it psychospirit, like what is mind, what is conscious? Like we have words for it.
Mhm.
But like what is it really? And you know, how do we make sense of it? And so seeing that continually butt heads and like people have this experience that can't quite fit into this framework of
Right.
medicine or biology or philosophy or religion. It's just sort of like it defines quite any paradigm perfectly. And so I love how it continually knocks me off my feet of like, I think I understand something and I don't. And I think I understand this and I don't.
Interesting. One of the things I find fascinating, kind of along those lines, is with psychedelic work. I do a lot of ketamine assisted psychotherapy, specializing really in complex trauma, and is it's non-linear. Like the idea that there's like a linear story that emerges just goes out the window. Like,
Yeah, or that there's your depth isn't so much that you can plummet and get to know it fully. Like somehow you're gonna get into the human mind and solve it like a puzzle and it'll be just this black and white linear thing. And so yeah, saying another way, it's like non-linear because it's not. It's,
right.
it's
Yeah,
just
I
a
try to
thing.
steer people away, both clients and trainees, from like, we're not searching for the aha moment. Like, that's not what this is. You're not going to like suddenly be like, oh, I get it. Like, it's all about this thing. And now I'm better. Like,
Yeah,
you know,
that I'm gonna fix myself and I'm gonna get a problem to solve. It's a very hard thing to unwind, both in the patient and in the clinician, honestly.
yeah. Well, and that's a really interesting question. You said, if people having to unlearn things and, I mean, I'm aware of, kind of research methodology, and maybe this seems like a bit of a leap, but kind of weaving those things together, like, you have done a bunch of psychedelic research and you all have very much influenced the field in terms of kind of moving that forward for people who don't know. I mean, the MDMA research and psilocybin research, is that accurate?
Yeah.
And so, I'm really kind of curious, like what do you see as, really exciting about what you have all done with the research? But then, what are the limitations? And of course, there's methodology, but then there's also this piece about kind of that you're talking about, like philosophy of mind. And are we really encapsulating the experience? And is it similar or different when people are in psychedelics? And that's obviously a huge opening to really speaking at whatever place that you want about that. But those are some really interesting weaving together.
You know, not being a psychiatrist at first I thought was a disadvantage, but now people have pointed out, and I really feel like it is an advantage because I wasn't stuck with necessarily these paradigms of what was going on. And so I was
Mhm.
able to like see the limitations of the tools and the methods we have. And that's not to say you throw them out, but at a very basic level, you're describing something inside of you that you put words on. Like I'm experiencing grief or sadness or anger, but that's just sort of capturing it. And then you read something and you call it depression or you call it trauma. And then I'm interpreting that and putting my label on it. But really,
Mhm.
there's a lot more unknown than is easily that is recognized. And so people quickly go to a diagnosis of I have depression. Or I have people that come in to do I have depression, I have trauma. I said, I don't know. He said, I have the doctors tell me both things. And they feel like they're the problem. And I
Mm.
say, actually, it's not you. All you know is you don't feel right.
Yeah.
And then you are describing it, and then you've read somewhere or somebody's labeled that, and then you start telling yourself that thing. But it's actually, can we have beginner's mind and really get down to like not put a label on it, but figure out what it is that you're feeling and what's happening, and then build on that. And so I've really been able to see some of the limits of, so, so we do standardized testing like the mini or the skid to make a diagnosis. And then we use validated scales like MADRS or um, PCL, which are fine, but they're tools. They don't. And so I see very often in the field, certainly with sponsors, but even the CRAs, or somehow like it's black and white, that if you fill out this thing, then you either got 20 or above, you got depression. If you don't, then you don't, or you don't have trauma in this. It's like the human mind is way more complicated than that. And so I think I'm really seeing the limits of what we
Mhm.
have. And like this is pushing us beyond sort of what we think. And there's real repercussions. I just was talking to somebody yesterday, and he's like, he's been diagnosed with PTSD, and then he got treatment, he got some better, and then somebody told him he had OCD, and then he went back to a different hospital. Somebody told him he had bipolar, and so it's
Yeah.
confusing for
Right.
people. So I don't know if that answers sort of what we're going down to, but I
Well,
see
what
that
I
like
hear
this.
you saying is, that we're trying, tell me if I've got this, if, that we're trying to sort of, what is the right word? Break down into measurable components, some elements of the human experience that might not fit into standardized testing. And then depending on what the lens of whatever professional is doing the evaluation and whatever knowledge base they're coming from. And now I'm branching into my own experience. I used to do assessment for
Yeah,
like years. And so I've lived this on multiple levels. And then somebody tells you one thing, and then that also, as a patient or a client, that also then informs your experience,
that's
and it's
right.
also going to inform the way in which you're going to present yourself to the next professional. And then we go into this rabbit hole of trying to take, really, experiential phenomena like lived experience and encapsulate it, right? Which has really like been really the core dilemma of psychotherapy outcome research all along. Like, how do we measure it? What are we measuring? How do we affect change? What are we looking at?
Yeah, it's it actually, it makes me think of Schrodinger's cat. Like the observation is affected by the observer. You can't have an um, you know, in physics, and so, and that's okay. I think where we go awry potentially is if you like don't realize that's going on, and
Mm,
you
mm,
it's like I describe it as a flat Earth problem. So like if you know like you have this paradigm that the Earth is flat, but you're not, but there's people that are saying is it round and flat, and there's a whole debate about it, but you got to work pragmatic like it's flat, it's fine. But if you forget that that's what you're working out of and you don't realize there's a question, then it can lead down to some rabbit holes.
right. I mean, it's super interesting, right? Because like CBT used to be the gold standard in, psychotherapy, and very easily measured, easily encapsulated. We can like more easily measure change. And now that's kind of out of vogue. And yet there's a reason why it existed. And it's not like those methodologies just went away. But as
I
we,
would, because I'm not in that field, like I'm in it, but I'm not in it. I
yeah,
always think like these three-letter acronyms are gonna
this is the new big thing.
I'm gonna do this three-letter thing and this is it. And it's just like, and I see therapists struggle with that because they get it attached to that. And then when the person doesn't fit exactly into that, they can't quite ram them in and they get frustrated with it. And then it's like the patient becomes a problem or it's
Right.
like, but the human psyche can't fit into a three-letter acronym.
That's so funny. I just told Signy today in our morning that I was like, maybe we need to come up with an acronym. We both just laughed.
So I would love for there to be an acronym.
Right, right, right. Maybe we can, come up with one. Um, well, so, this is kind of talking about, just bring some of the challenges in the research. And then that kind of, brings the question of, you know, bringing psychedelic assisted psychotherapy into the mainstream. Like, we're obviously not there. We are there with ketamine, and I'm happy to talk about that because that really is psychedelic-assisted psychotherapy, and people often don't think of it as such. Um, but, we've got these sort of boxes at the human psyche. We've got the research, and it's has its limitations, and it can only carry us so far. Then we've got the human pieces about how do we create safety and who can do that. Those are some things. And so, as you've been instrumental in moving, this ball down this field, kind of ideally headed towards, some kind of way in which it opens up and expands access more. What do you see kind of the challenges that we're all facing here, and how can providers interested in the field kind of take some of that to heart?
I think ketamine is a good example in terms of you see it playing out in ketamine, right? So you practice ketamine a certain way, but most of the people that come to our clinic that have been through ketamine, they went to an office, somebody gave them ketamine, and they checked on them like somewhere in between, or they didn't, and then they finished and went home. And that's what most people think ketamine therapy is. And so it's not like the medical or the field has decided this is how you do ketamine therapy. Like there's people that don't believe that you need to do therapy or don't do therapy. And then obviously you're in the camp that think that's almost criminal that you wouldn't do it any other way.
Like, of course you would do therapy, and here's a good idea. You actually sit with them. People are like,
Yeah.
what? You sit with them? That's
So,
crazy.
so I mean, I think that's some of the challenges in the field that we're seeing playing out. And so medicine, there's no paradigm for therapy plus medicine. And the FDA itself said that we don't regulate therapy. And yet no one feels comfortable to give somebody high dose psilocybin in a room by themselves. And
Right.
so the person is in that room, and then you hear them called all different things, therapist, a mentor, to support. You call the thing being done all different things like therapy or support or psychological mentoring or guiding. And
Mhm.
so I think really coming to grapple with that this is some new thing that doesn't quite fit into the old box. And even therapists struggle with it a little bit because they think it's just therapy, but there is a real medical component to this. I mean,
Sure.
there's a strong physiologic thing that happens, like people's blood pressures go up. They can, and most therapies can't quite lead you into this deep space. And there's a real physical thing that happens, and so I think that's where I say people want easy answers. Like it fits into this medical bucket or just this therapy bucket, but it's like, what if it's a new bucket that we haven't yet fully don't know yet, and we need to do more studies or look at it and have a more of a humble approach to it to say we got to figure this out. This is really interesting. It's really exciting. It's potentially can help people deeply, but we don't know everything, and so let's ask more rather than come to this is the way to do it. And so I think that's one of the challenges when something new is coming out is people want a solution that you're going to roll out, and nobody
Right.
wants to hear that it's not quite worked out yet.
So how do we do it? Like, how do we, those of us who are interested in the field and people who want to get in the field and participate in that, like, how do we create a new bucket? Like, I mean, you're living this firsthand, right? Like, meeting with FDA people and living policy and doing research. And, that piece is of critical importance. And how do the others of us in the field like support that? And kind of like I love that, right? It's the integration. And that's one of the things, for people who, maybe don't know, but that we hit with MDMA, that the FDA was applying drug research methodology and overlooking some core tenets of psychotherapy outcome research methodology. And there is no third bucket where those two things coexist that is scientifically validated
Right. So like
based on previous methodologies.
that's right. If the framework doesn't work, rather than keep trying to cram it in the same framework, maybe you need a new framework. So to answer your question, I don't know if I have the answer to that, but what we've done, where we've learned, is to treat a lot of people and really pay attention and learn and talk about what we happens, and then we write studies to answer that. So, we've done a group study and learned a lot about group versus individual. We've done couples work, and that's very different than individual. We've treated with a lot of different medicines from psilocybin to MDMA to LSD to 5-MeO to methadone, and this new drug RE-104 and different disease states like depression and trauma, and having that allows us to sort of see like what's underneath going on there. And so it's created a space for us to learn and then be able to write and publish and talk about it. So that's how we've done it.
Mhm.
Um, but I guess I would say like I think that we need this field more than any is going to need more disciplines, not less. And that as a physician, I can say if it's gets relegated to the medical world, it will not solve it. We need therapists, we need social workers, uh, we need people in other specialties. An acupuncturist we work with who's brilliant has brought in a lot of insight. And so, because other paradigms may have views in that are going to be inherently helpful, so we have to figure out how to get those voices heard and and uh, and have that insight as things emerge.
That's interesting. Like even we were having a discussion in our training the other night about the role of like blood pressure monitoring if you're not a medical professional and you're doing, lozenge work in your office. Like can you or can't you take somebody's blood pressure? Or can you or can't you take a pulse ox? Whereas if I've got a pulse ox on somebody and their pulse rate goes up dramatically and it stays up, that's telling me something about their psychological distress as well as something that may be an adverse outcome on a physiological level. So that's a very simple example of how that plays itself out. And if we try to put it in the two separate silos, then that's a big problem.
Yeah, and things have happened both ways. Like people have gotten, well, we have not had that fortunately, but people have gotten chest pain and people are like, oh, that's psychological, and it was actually a heart attack, and that happened during an MDMA session. And conversely, people are having truly heart pain and not cardiac pain, and then they have EKGs done that's sort of disruptive to their thing. So it does take a real nuance to sort out, well, what is happening with this person?
Right. Well, and it's interesting because, those adverse outcomes pieces, like, I'm not saying that I have an answer to this, but, that balance of like, okay, so we have some lived experience of not only statistically, but actually seeing this where somebody's having a heart attack and, we can witness some adverse outcomes and we've seen how they've been handled well and not handled well. And then we also have data to suggest that there are positive benefits for a clinically significant number of people. And in fact, they may be quite positive outcomes. Like what are your thoughts on balancing that? Like, how do we balance the possibility of adverse outcomes with the fact that we also are treating, adverse outcomes or, suffering?
I mean, that I don't I don't struggle with that much because in medicine there's nothing without risk. And so
Right.
as an oncologist, I gave lots of drugs to lots of people with very serious side effects, but it helped them treat their cancer. And so, I mean, that's just part of practicing medicine. There's not a single intervention in medicine, not a single pill, anything that you give or take that doesn't have a risk to it. And so you just have to weigh the risks versus the benefit. And so, um, in fact, I found that interesting somewhat. I've written an editorial around this that I've not yet published, but that, in oncology, a lot of times drugs have gotten approved, or we think like we use drugs that are quite toxic with 1, 2, 5% benefit. And we think that makes sense. And patients want it, and doctors want it, and the society is okay with it. And then people with trauma, which I find to be as debilitating as cancer, uh,
Mm.
people lose meaning, they lose connection to relationships, they're not able to work. There's a lot of similarities, and yet the tolerance for some of the risk is much lower. And I think it's not as well understood how debilitating trauma and mental health can be always. And so I think that there is real risk, and we need to continue to study it and really do a better job of screening who people are that's not appropriate for, because it's not right for everyone. It's not a magic bullet. But at the same time, we don't need to be scared of risk. We just need to say it's 5%, it's 3%, whatever it is. And that's,
Right.
when you get anesthesia, when you get colonoscopy, when you get surgery, when you take an antibiotic, um,
Yeah.
Levaquin can cause Achilles tendonitis. I mean, it's like, yeah,
Right. Totally. Yeah. So we're almost out of time. So just, a minute and 30 seconds ish. I'm kidding, but or less, I could ask you about training or I could ask you any things, but really, if you were a practitioner, assuming that you are, already have, experience as a therapist or a medical person, what is your recommendation to people who are interested in getting involved in this field? What do they need to look for? What should they be doing? How do they get involved?
Getting involved as a therapist, you mean doing therapy?
More medical person, like assuming that base level that we're already operating from that perspective and somebody's interested in making the jump into psychedelics, are there thoughts on like training or where the field is going and ways for them to kind of jump in?
Yeah, I mean, the field is certainly growing and evolving, and I think that training is going to be a big part of it. And there's been an emphasis on didactic, and there's been a lot of courses. Our approach is very much supervision and hands-on. I think that you have to get your hands dirty, be humble, and learn, um, because it is a new thing. And that's what I would recommend if you're a therapist, go to a place where there's experience and learn with someone that's done it, because there's a lot of nuances that you are not going to learn in the classroom or in a book. And and you really need a community of people that are learning. So our therapists, we meet weekly, but we also go over other things. There's others monthly supervision, and that's where you're going to improve a lot.
Yeah.
And so, yeah, so I think training is going to be important. And I guess just to, this seems easy to say, but it's hard for all of us, is to like, you learn a certain approach, and it's really valuable, but also be open to the limits of that approach when you're coming to this, and not try to make this fit into that approach. But don't throw it out. It's helpful. You gotta stand somewhere, but just
Yeah.
know it's just a stance.
I love that. Like take a kind of scientific evaluative approach, be open to the fact that what you're doing isn't working, but also be open to the fact that what you're doing is working and try to
Yeah,
keep it.
and I would say this is challenging, because it can't but stir your own biases and your own. And so, in order to really do this work and be in the trenches with people, it will require a lot of you, and you'll have to continue to be self-aware. Otherwise, um, I think it can be detrimental for people.
For sure. Well, I really appreciate your time. Anything else you'd like to add?
No, I enjoyed the conversations. Thanks for your
Great.
questions.
I very much enjoyed the conversation as well, and I really appreciate it. And for our listeners, this will come out in several weeks. Please watch for it and check out our other episodes as well. And thank you again. Thank you so, so much. I'm really honored for having the opportunity to talk with you in this way. Thank you.
Thanks. All right.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.